Good morning, everyone. So before I begin, I would like to thank Dr. Vijayalakshmi for including me in this instruction course. I'm quite thrilled to be sharing the stage with such great and experienced surgeons. Thank you, ma'am. So needless to say, the incision construction is of utmost importance, like all the other steps in phacoemulsification cataract surgery. So whether placed on the cornea or limbus or the sclera, incision is the gate to reaching the intraocular surgical space. So it influences the fluidic balance of the anterior segment, lays foundation for all the additional steps of the surgery, and it also influences the immediate post-op period. So if you, a proper incision would be, the best for a faster recovery and a better visual outcome. So our aim is to create, like the previous speakers, Dr. GJ and Dr. Ramamurthy sir has already mentioned, that it is to create a watertight, self-sealed wound to prevent intraoperative and postoperative complications. So there are various points to consider before we start making our incision. Any pre-existing astigmatism, access, location of your main port and side port, the size of your main port, shape, the form. And wound architecture is of utmost importance because it affects the degree of surgically induced astigmatism, the wound strength, and the wound healing. So depending upon the size and function, a cataract incision is referred to as a main port or a side port. So let's begin with the main port because it is of more importance. So it could be a scleral or corneal incision. It could be a superior or temporal incision. This is purely based on the surgeon preference or the surgical expertise. Most beginner surgeons start with a superior and then move forward to temporal. Also, any pre-existing astigmatism has to be considered. So nowadays, most phacosurgeons are using the temporal approach because it uses, it induces a lower grade of surgically induced astigmatism, and there is much better surgical accessibility, especially in cases of deep set eye, etc. So there are various advantages and disadvantages. I'm not going to cover that because we are already quite familiar. My topic is only to consider the difficulties in the incision. So let's move forward quickly. So a clear corneal incision is obviously the most preferred method. So according to Dr. Uday Devgan, there are 3 rules for corneal phacoincisions. Stay peripheral, make it symmetric, and keep the incision architecture consistent. So if you can see in this picture, a good form would be a more or less square incision placed exactly on the limbus with slight nicking of the limbal blood vessels. It is great for long-term sealing. It is further away from visual axis and it has less atomatic effect. This incision, as you can see over here, the clinical picture, it is very much into the clear cornea, more or less avascular, so it has a weaker long-term sealing effect, closer to visual axis and inducing more astigmatism. Symmetry of the incision, basically we are concentrating on getting an equal thickness of roof and the floor. So your intrastromal movement of the keratome should be aimed towards entering almost mid-stroma and avoid this kind of an incision, this kind of an entry that is having a very shallow roof and a thicker floor. That is what gives us this chevron appearance or a triangular shaped inner lip. So the dimensions of the incision, of course, width and tunnel length are important. It should be a radial entry, straight in and straight out. Proper incision width causes less atomatic effect. Oblique entry, different in and out paths, incision may be too wide and it causes more atomatic effect. Also with the oblique entry, there is another problem of excessive aqueous outflow. So let's move on to a video just showing an ideal main port. So you make a linear groove of 100 microns depth using the side of the keratome, enter AC without dimpling. So the AC is entered normally without causing any dimpling. So this is another video showing a main port construction. I'm just going to move forward quickly. So make a scleral groove as you would in an SICS incision. A scleral tunnel is created and the AC is entered with the keratome. So this is a beginner video. You can see there is a slight bit of hesitation entering the AC, but still the beginner surgeon has managed to create a good square-shaped incision. So let's move on to side port now. So the purpose is to provide entry access for anesthetic or capsular staining agents or viscoelastics, and also to facilitate the bimanual techniques of irrigation and aspiration, or in complicated cases, vitrectomy. So location is appropriately placed away from the main phaco incision, provides an optimal angle for intraocular manipulation. A good form or an ideally placed side port would be 60 to 90 degrees away from the main port, radially placed. So first of all, before you start, you should ensure sharp instruments and tense eyeball. So let's see the construction of an ideal side port. This is also a video taken from a beginner surgeon, but she has managed to create. So there's a slight bit of limbal vessel nicking, entering the AC parallel to the iris, and exit. Another ideal side port construction. Okay, so let's start with the incision difficulties with the main port and the side port. Both could be either too posterior, too anterior. Too posterior meaning more towards the sclera, and too anterior meaning more towards the clear cornea or beyond the the limbal zone, the limbal vascular zone. So it could be a too long an incision, too short, and the configuration could be abnormal, and in worst cases, it could lead to a DM detachment. So main incision of utmost importance because it can alter the astigmatic profile of the cornea, induced irregularities, and cause issues with intraocular movement of our instruments. So novice surgeons may make an incision that is too long, too short, or misplaced. So in this video, we can see sorry about the focus because this is from a beginner video. So obviously we would have problems with the centration, which is expected. You can see the inner lip chevron at the end of the incision. This is with the 2.2 keratome. So there's also a dimpling. You can see the traction folds on the cornea as she entered. Next is the same effect with a 2.8 keratome. So that is clearly demonstrated. The side port being too anterior into the avascular cornea. With this video, you can see. Okay, so let's consider each one. So if it is a large wound, or you could have the large port, as in mainly it is in the main port. You could have excessive aqueous outflow, which causes the AC to collapse during the surgery. If it is a short tunnel, you could have the wound which is not very well self-sealed, and post-op wound leak could occur. If it is a long tunnel, instruments could cause traction folds and reduce visibility in the AC. It is a superficial incision, like we saw earlier in the, with the chevron. A thin corneal flap may also get torn with the phaco tip. So take-home messages are that an avascular incision will never quite fully heal, and it can be opened years later with a blunt instrument. They also cause more astigmatism and more foreign body sensation. So always ensure, before you begin, all your instruments are sharp and a firm globe. Customize the incision location according to the surgeon's preference and anatomical factors like a deep set eye or pre-existing astigmatism, or if you're planning a combined procedure like, say, a trab. And you should always stay peripheral, keep it symmetric, and keep the architecture consistent. Thank you so much.
Thank you.